Hello, thank you so much for joining us. My name is Ariana, and I'm one of the peer mentors for the learning community. So thank you again for being here today for a really important discussion, and I'm glad you could all be here with us. So today we're joined by Dr. Martin, and she's going to be discussing really the importance of inter and intraculturally informed healthcare and explaining what that is and why it's so important in the health field. So she's going to go ahead and take it away from here. So thank you again for being here with us.
Sure.
And thank you as well to Professor Lopez.
Hi, you all. As Ariana mentioned, I'm Dr. Jamela Martin. I am an assistant professor in the School of Nursing, and I have Ariana in assessment lab right now, and I will have her again in the spring for research class. And then I think you have another mentor, Chevee Ward, and I've had her in the past, and she was in my research class as well. So if you're in nursing, I know you're all health sciences students. If you're in nursing, you will certainly see me through several of your various classes in your program. Let me tell you a little bit about myself before we get started. I've been at ODU since about 2013. I have been a nurse since 2004. So my first degree was in healthcare administration from North Carolina State, and I finished that in 2000. And then I decided that I wanted to go back to nursing school because I really just wanted to work with people. So my first job really was more in administration, and it wasn't fulfilling me as much as I thought it would. So I decided that I would go back for my second degree in nursing, and I did the second degree program at ODU, at UVA, University of Virginia. And that was a 2-year program that earned me my Bachelor of Science in Nursing. From there, I moved to Atlanta, and I worked in the neonatal intensive care unit. So I got to work with the teeny weeny little babies who I miss tremendously. I worked in the NICU for about 6 years, and then I decided again that I wanted to go back to school because I love school. And so I went back to school to obtain my master's degree in nursing and then my PhD in nursing. So that took me about 5 years, an additional 5 years year round. I finished that in 2013, and then I moved down here from Charlottesville, and I'm now teaching at ODU School of Nursing. And I teach primarily nursing research. I teach in the skills lab sometimes, in the health assessment lab. I also teach community health every year. And then I just do a variety of different activities and talks and things with the nursing students and students around campus. I participate in some research studies. So if anybody knows that they like research as they get into their health sciences careers, please feel free to reach out. Most recently, I participated with a faculty member and we mentored 5 students from across campus. So they weren't all nursing students. There was a medical student, there was a social work student, and then there were 3 nursing students. So it was a great experience. And so I do have lots of experience mentoring students in both the community as well as in your coursework in clinical settings. So today, though, we are going to talk about inter and intraculturally informed healthcare. This is something that I don't that I participate in terms of writing papers and books and giving talks. And some of you may have been present for the Weathering COVID talk that I did with colleagues at ODU and from various Virginia resources a couple of months ago. So today, that's what we're going to talk about. I do want to give a little caveat. I have a young son. He is at home, so I'm teaching from home. So you can see my house in the background. I have 2 dogs and a cat, and they will probably bother me at some point. So if I if I pause while they're barking or put it on mute for just a second, please forgive me so that I can get them settled and we can get back to it. So again, this is where we're talking about intra and interculturally informed healthcare for health professionals. And again, I know that many of you are not, some of you may or may not be going into nursing. And so this is not necessarily directed at nursing. It's for all healthcare professionals. Some of this information has come from the Virginia Department of Health, Office of Health Equity, and the Division of Multicultural Health and Community Engagement. So I do want to give credit where credit is due. Our learning objectives for today, we are, upon completion of this learning module, you should be able to explain the components of culture, describe the impact of disparate treatment in healthcare, appreciate the importance of being culturally informed, describe some cultural health beliefs and traditions, and utilize different communication strategies when working with people of cultures other than yours. So why do we need to focus on culture and competency in provider-patient and provider-provider relationships? Because it's very important. Effective communication is the cornerstone of healthy relationships in all areas of our lives, but especially in our professional lives. So today we will pay attention to our communication styles and our communication skill sets and begin to explore how culture and cultural competency or culturally informed might impact your interactions. We live and we work with diverse populations who experience life through different lenses. So to effectively communicate with and engage individuals in treatment or health maintenance, we need to be sensitive to differences in clients' needs or barriers that might exist. We will explore the importance of understanding how addressing culture and language are essential to equitable good health outcomes. So a couple of things that I want you to think about why this is important. Think about your first job as a new graduate after completing your health sciences education. As we go through this, I'd like you to think about your experiences with your colleagues as you transition from student to professional. I'd like for you to think about your communication style with your clients and patients, as well as the people that you work with. And then what kind of influence do your colleagues and patients' communication styles have on your professional relationship with them? So where we can't expect to be perfect and understand all cultures, we can expect to understand our own communication styles and the communication styles of others. So what is culture? I'm going to show you a quick video here, but we live and we work with diverse populations who experience life through different lenses. So I've already told you this, to effectively communicate with them and engage individuals in treatment or health maintenance, we need to be sensitive to their differences and their strengths. So we'll explore those, the importance of understanding how addressing culture and language leads to better health outcomes for patients. Let's take a look. What is culture? There we go. So one definition of culture is that it's a set of learned beliefs, traditions, and principles for individual and collective behaviors that members of a particular group commonly share with each other. Culture can include any of the aspects which make us who we are, including race, ethnicity, gender, sexual identity or orientation, profession, religion, where we live and grow up, our geographic location, and the list goes on. So there are multiple memberships in many subgroups that each of us have, and all of those contribute to our individual personal identity and our sense of culture. You're not just one culture, and everybody has a culture. But remember that culture is not just defined by a person's race or ethnicity. Every person, even if from the same ethnic group, has different experiences that contribute to their culture. So as you think about this definition of culture, I want you to take a quick poll so that you can think about what are the components of your culture. So it looks like most people chose race as their most influential component of their culture, followed by ethnicity, and then religion, and then education and socioeconomic status. So that's typically what a lot of folks think about when we think about culture. And our ethnicity and our race do play an important part in our culture, but so do all of the other factors here, as well as many, many others. So we're going to take a look at some of the other ways that our that our individual experiences and lives influence our culture. Okay, so how many of you put any of these on here? Did you know that there were these many options for components of culture? We have age, physical abilities, gender, race, ethnicity, sexual orientation, but then we also have things like appearance, political thoughts, marital status, functional specialty, military experience, job classification, thinking styles, parental status, whether you're a parent or not, your creed, your personal beliefs, your work background, and your communication style. So all of those influence and impact your individual culture. All of us, though, need to be aware that our exposure to stereotyping can start early. So we have our own personal views of culture and things that are right, things that are wrong. But we know that it is important to understand that the origins of our bias, it's important to understand the origins of our bias and to consciously practice awareness to treat people fairly and to not contribute to health disparities. So the images that children see, they form lasting impressions. In children's books and in movies, evil is often the dark and the goodness is often the light. In these pictures from cartoons and books, the Black man is portrayed as a comical character and he's crude. The Native American is uncivilized and often attacking, and it's observed that the character Aladdin, he gets whiter as things improve in the movie. So you can see at the beginning of the movie that he's more brown when things were bad for him and he was poor. But by the end of the movie, he was light and things were bright and he had money and things were going well for him. In addition to ethnic and racial stereotypes, there are myths that abound about princesses needing to be rescued, older folks that are doddering, and men that are fighting fearlessly. So today's adults grew up with these images and they subconsciously carry false racial associations to this day. And these messages are often enforced and reinforced by the media. So pay attention to what you see and what you've read and experiences that you've had as a child and as an adult, and think about the ways that those experiences and those exposures could contribute to biases and stereotyping from your end. Again, our media can sometimes perpetuate stereotyping and biases. It's important to make you aware and to provide concrete examples of how the media does this. So headlines and news stories sometimes use different language in describing and analyzing behaviors based on the race of the individual involved. The Katrina posts on the left state that the white flood victims found food to sustain themselves at a local grocery store, but the Black flood victims looted food from a grocery store. So our language and the way that we communicate about culture really impacts the way that people see various individuals. Another example is the Virginia shooting of work colleagues. It was framed as a racial crime in the headline on the right, at a time when little was known about the situation or the relationship of those involved. And you can see it says race murder in Virginia, Black reporter suspected of executing white colleagues on live television. This is referring to the Virginia Beach shooting. And of course, now we know he wasn't a reporter and, he did a bad thing. But before we knew anything about him, this was the headline one of the headlines that we saw. And then the tweet on the bottom of the slide on the right observes that news stories about the recent execution of Black worshipers in Charleston, South Carolina, were speculating that the shooter suffered from mental illness, a consideration often not suggested when the perpetrator is a person of color. And again, another example of communication. So further confirming that racial messages are slanted in a particular direction is a study called the Bound Encoding of Aggregate Language Environment. It's called the Beagle Project. And what they did was that they looked at 10 million words from a sample of books, newspapers, magazine articles, etc., which represent American culture. And the sample was equivalent to what the average college level student has read in his or her or their lifetime. Researchers statistically analyzed the associative strength between the pairs of words and provided an estimate of how often Americans have seen or heard the words paired over their lifetime. And there are some strong associations listed on the slide. So it's important to recognize that many of these associations are not positive or fair. And so here it shows stereotypes in our culture, word associations in literature link some characteristics more to one racial group and gender than another, embedding lasting, often destructive impressions in our cultural memory that affect our ability to see people as individuals. So here, these are the association numbers. So this is how strongly it was associated. They associated Black people being poor, violent, religious, lazy, cheerful sometimes, dangerous sometimes. Females were distant, warm, gentle, passive. For white folks, they were considered more wealthy, progressive, conventional, stubborn, successful, educated, and dominant. And males were considered to be leaders, logical, and strong. So the previous slide showed us how we've been exposed to thousands of messages throughout our lives about how things work in the world. And we know that some of the information that we're given is actually not based in fact, but it actually can stick with us nonetheless. Those behaviors and beliefs, those beliefs lead to behaviors towards other people that can have devastating effects on the future of our community and on the future of healthcare. So let's take a look at how implicit bias affects healthcare.
So in healthcare, bias comes in various forms. And I would say there's three primary ways that we could actually track bias. One, of course, is in interpersonal interactions, let's say between a patient and a provider. So the unconscious ways that we may have associate certain groups, certain gender identity, people with certain gender identities, people from certain racial or ethnic backgrounds, manifests in the diagnoses we're making, the interactions we're making with the patients, as well as the warmth with which we're working with them, which impacts the amount of trust that they have in the providers themselves. How does that manifest? One of the major ways that's been studied and shown and reported over and over again is pain management. So patients with darker skin, African Americans, receive lower dosages of pain medication across the board, from infants to the elderly, for the same types of ailments they come to practitioners for, because of assumptions that are being made around addiction or their ability to actually be truthful around what they're experiencing. The second way bias really plays into all of this, particularly unconscious bias, is the internal dynamics of organizations. how employees and staff members communicate with one another, team collaboration, team dynamics, but as well as performance reviews, reviews around compensation, who gets to be promoted, who gets to be a leader of an organization, of a team, based on assumptions that we may have about those people, purely based on phenotype, their origins, whatever that may be. And the third way bias really plays out in healthcare, and this is, quite well documented across the board, is its costs, wasted costs. So racial bias, just one particular identity that we're concentrating on, costs the US economy, the healthcare system, $310 billion a year. And for me, I just want to think about what can we do with that money if we didn't have bias in the world.
Okay. So think about that. What could we do with that money? And a lot of people don't think about the fact that these outcomes of implicit bias in healthcare, they not only affect the individual at the individual level in terms of their outcomes, their healthcare outcomes, but it affects the entire system. And so if you have people who are returning to try to get the care that they need, that can be a drain on the system as well. So there are systemic factors associated with implicit bias, and it's critical that we begin to really take a look at how we can break down some of those barriers. So how can we become culturally informed? Well, I don't know if you noticed in the first video, she talked about the iceberg model. Culture is visible and it's invisible. So the iceberg model here shows us that there are surface level culture, things that we can see, that we are aware of. And then there's deep culture, those things that are out of our conscious awareness that might be invisible, but things that we also need to be aware of as well. It's important to note that all attributes of a person are not evident at first glance. We tend to generalize from what we see, and our stereotyping often leads to false conclusions. So we come to conclusions usually based on our own culture or what we perceive to be the other person's culture. So again, it's that self-recognition and communication that's very important. Cultural assumptions. So providing quality patient-centered care requires an understanding of the ways in which our own culture influences our interpersonal interactions. And we need to be aware of the many messages that we've heard and absorbed about other people as we grow up. Some we gave little thought to, and many we didn't even question because that's, people around us were of similar cultures or slightly varying cultures. And sometimes we were misinformed or we developed opinions that are wrong. So it's okay to look back at those opinions and evaluate and say, my thought process regarding this gender of people or this religion of people, is that really correct? Or do I need to take a minute to learn a little bit more so that I can better understand? In order to build relationships with people of different cultures, we have to be aware of our own worldviews. So healthcare providers and recipients each walk around with broad cultural experiences, which they bring to the healthcare encounter. And it helps to be mindful of the cultural dynamics in play for both the patient and the provider, but also between yourself, the provider, and your colleagues who are also providers. We will encounter people with different characteristics, people from different countries, seniors and teens, people of diverse sexual orientations and identities, people of different faiths, and individuals with special needs. You will encounter all kinds of different people. And we're likely to come to conclusions about the people that we meet based on our own culture. So all of the people that we work with need inclusion and equity, as well as respect and sensitivity in the provision of health services. And then when that's not provided to individuals based on some erroneous cultural assumption, then healthcare inequities can occur. So what are some of the impacts of disparate, in other words, different treatment in healthcare? Let's take a poll. Now, I don't know, hopefully you'll be able to select the correct answer on this one, but we're going to launch another poll here. So we have 66% of people voted so far. Making sure everybody's still with us. Okay, we're going to go ahead and end the poll. And look at these results down here. So, let's see. Whoop. Can you see the entire poll in my screen? Or in your screen? Okay, so what are some of the health implications of cultural stereotyping and bias in healthcare? These are facts that we know that people of color are less likely to receive tests and treatment. Individuals with disabilities report negative interactions with providers more often than those without disabilities. People of color receive a lower quality of care. People of color are provided less desirable services, such as amputations and less or no pain medication. And what that means is that, if they're having some issues with one of their extremities, an arm or a leg, and the options are to try to save that arm using some other treatments, or go ahead and amputate it, which means to remove it. More often than not, or they're more likely to be offered the amputation as opposed to the other type of treatment. People of color experience higher mortality rates, and transgender people are refused treatment or verbally harassed more often. So those are just a few examples. And remember that culture is not just race, it's not just your sexual orientation or your ability or disability. So we're still in the process of better understanding all of the ways that a person's culture can lead to some implicit bias, which then leads to disparate care and health inequities. I'll share the results. So the answer for that one was all of the above. Okay, so we do now have a better understanding of culture and how our culture shapes our perceptions and bias. And this, like I said, the studies do show that some healthcare professionals provide unequal treatment to people who they perceive to not be of their own group. The Institute of Medicine has found evidence that whether they know it or not, many health professionals treat their patients differently depending on the patient's race, ethnicity, gender, and socioeconomic status. And those are the areas where we have the strongest evidence that we know that this is occurring. And we're still, as I said, working on evidence in other areas. Differences are known to be linked to disparate treatment. Disparate treatment in healthcare settings results in health disparities for individuals that differ by race, ethnicity, gender, sexual orientation, and socioeconomic status, as I mentioned. So when you see the word disparate, just remember that that means different treatment. As healthcare professionals, we would like to think that we treat everyone the same. I would like to think that I treat everyone the same. But that would be ignorant of me to think that my culture doesn't influence the way that I treat people. So I have to remain cognizant of the fact that it might. A review of over 100 studies revealed the following things that we discussed in the, or the previous things that we discussed in the poll regarding the lower quality of care, less desirable services, higher mortality rates, etc. So what are some strategies to promote culturally informed care? Can you really be culturally competent? Nope, you cannot. And this is my little reminder to go vote also. But no, you cannot be culturally competent. Cultural competence insinuates that you are able to fully understand all of the cultures around you. And that's just not possible, because remember, we talked about culture is not just race and it's not just ethnicity, that everybody has an individual culture. So to be culturally competent is not really possible. So you will see a lot of terminology saying culturally competent, and it's just not necessarily correct. What we like to call it now is culturally informed care, which is the preferred terminology now. Okay. Being culturally informed is a developmental process that evolves over an extended period. So both individuals and organizations are at various levels of awareness knowledge and skills along the culturally informed continuum. So yes, you can be culturally informed. It's necessary for organizations to develop culturally informed guiding values and principles for their employees. As the studies previously discussed and clearly demonstrate, if healthcare providers are not trained, problems often develop between providers and their patients that ultimately result in patients not receiving the proper treatment, which then leads to that $310 billion loss that we discussed previously. So here are some culturally informed guiding values and principles. At the organizational level, the organizations should have a defined set of values and principles and demonstrate behaviors, attitudes, policies, and structures that enable them to work effectively cross-culturally. The organization should have the capacity to value diversity, conduct self-assessments, manage the dynamics of difference, and acquire cultural knowledge and adapt to diversity in the cultural context of the communities that they serve. Organizations need to incorporate all of the above in all aspects of policymaking, administration, practice, service delivery, and at all pieces of the puzzle at all levels of the organization. And then systems and organizations have to sanction, and in some cases mandate, the incorporation of cultural knowledge into policymaking, infrastructure, and practice. So hopefully you know what sanction means. That means that if there are situations, policies, procedures, individuals that are going against the goal of being culturally informed, that those changes need to be made, whether that means removing that policy, removing that person, that sort of thing. And then organizations have to embrace the principles of equal access and non-discriminatory practices in service delivery. And I want to just give you a note that these things, these principles and values, these tasks are not passive tasks. They must be actively implemented in the organizational setting with the intent of providing some sort of equity for everyone. Practice and service design. So at that level, we should be identifying and understanding the needs and help-seeking behaviors of individuals and families. That works towards being culturally informed. Culturally informed organizations will design and implement services that are tailored to or matched to the unique needs of individuals, children, and families in their communities. Healthcare practice should be driven in service delivery systems by client-preferred choices, not by culturally blind or culturally free interventions. So this is where the patient-centered care comes into play, where you are talking to your patients and making sure that your plan for them is their plan for them as well. And then culturally informed organizations have service delivery models that recognize all aspects of well-being as an important aspect of primary health care. Community engagement. Being culturally informed extends the concept of self-determination into the community. It involves working in conjunction with the natural informal support systems within culturally diverse communities. Communities determine their own needs, and community members should be full partners in decision-making when it comes to community health care and the services that are provided in their community and at healthcare organizations. Communities should economically benefit from the collaboration so that it's not just a take, but it's a give and take. And then the community engagement that we do as healthcare professionals should result in transfer of knowledge and skills among all collaborators. So we're not going in and dropping off knowledge and supplies, but that it's a give and take. We're accepting that knowledge and we're providing what knowledge they may need as well. Family and consumers. Family is defined differently by different cultures, of course, and family as defined by each culture is usually the primary system of support and preferred intervention. Family and consumers are the ultimate decision makers for services or supports for their children or for themselves. So it's important to consider family structure, and family needs when you're providing care to your patients. So what can you do As a student, as a new healthcare professional, what will be your job in order to help us move forward with being culturally informed? Well, you can be as open-minded as you can as you encounter people and practices. You can use an experiential learning approach, meaning push yourself beyond your cultural comfort zone and ask, challenge yourself, get out there and enjoy maybe some festivals or things that you maybe wouldn't enjoy just so that you can learn and be a part of other cultures. You can avoid stereotyping people and see each person as an individual. You can be respectful to all people and build trust. Develop and increase sensitivity to the needs of others. Again, that's where we are intentional and purposeful about seeing and recognizing and asking about a person's culture or their needs. Tailoring your interaction to individual patient needs, raising awareness and finding common ground, establishing diverse relationships in your own personal lives is quite helpful. Working as a patient-provider team, a collaborative process, improve and teach communication skills. You can offer care and services to meet the needs, such as interpreter services or dietary needs. Adopt logical, critical thinking skills. Let people define themselves, as you know, we're all appreciative when others allow us to define ourselves and not box us into something that they want us to be. And respect diversity and traditional treatments. So those are just a few of the things that you can do as you go through, not only as a licensed provider, but in your dealings with anybody in your life and in the world and at ODU and in your classes, is to keep these things in mind. Oops. And you can also stay informed. So I want to break away from this briefly because we're going to do a quick case study. This case study comes from this book, Diversity and Inclusion in Quality Patient Care. This is the second book of this series. It's a case compendium. The first book really talks as more articles about diversity and inclusion in patient care. This edition provides some case studies. So you have access to this book through the ODU libraries, and I encourage you to take a look through there and just look at the sheer variety of interactions and issues that people have encountered in healthcare that has shaped their experience or the patient's outcomes. So, and I did see briefly in the chat that Ms. Leanne said that the link to the book is in the flyer if you want to find it. It's pretty easy to search on the ODU library website too. Okay, so this is the chapter that I wrote for the book, and I wrote a couple of chapters for this book, and I wrote a chapter for the previous edition as well. This is called Ancillary Staff to Nursing Instructor Barriers and Bias. So I'm going to read it out, and then I'm going to actually have you guys join in, unmute your mics, and discuss this with me. So the case scenario: Mrs. R, a 63-year-old Caucasian woman with colorectal cancer, is admitted to a post-op recovery surgery unit after an ileostomy placement. The patient is known to have mental health issues and has required around-the-clock supervision. A gastrointestinal surgeon, the staff nurse, and a nursing student are caring for the patient. On the first day after surgery, the patient complains of shortness of breath to her nurse and the nursing student. The primary nurse tells the nursing student, "Yes, I know, it's been difficult to discern which of her complaints are real versus imagined. She's been a tough patient, so let's just watch and wait." When the complaints of difficulty breathing are unaddressed by the primary nurse, the nursing student decides to remain at the patient's bedside to observe and keep Mrs. R company. When the student recognizes worsening blueness around the mouth and the patient was losing consciousness, she immediately calls for help. So Mrs. R, the patient, her breathing status continues to get worse, and she needs to be resuscitated. So they have to do CPR on her. After they finish doing CPR, they order some chest x-rays. And the x-ray tech arrives, and recognizing that he will need to reposition the patient, he calls for help. But the nursing student is still in the room. So I'm not going to review the symptoms because for you all at this level, it's not necessarily relevant. What we really want to do is think about the communication and the interaction. But if you want to review the symptoms, you're welcome to go into the book and take a look. We'll skip on down here. So what was said? What was the communication that occurred during this interaction? After calling for help to reposition the patient for chest x-rays, the x-ray tech looked surprised to see a presumably young African-American woman dressed in blue scrubs arrive at the bedside. The woman briefly speaks with the nursing student and then proceeds to help the tech reposition the patient for imaging. As the tech is about to take the first x-ray, the African-American woman comments, "Wait, the patient looks rotated. Let me adjust her shoulders and her hips." With a look of surprise on his face, the technician asks, "How'd you know that? You're a student." After speaking with the nursing student and gathering a brief status report on the patient, the African-American woman introduces herself by first name only, assuming the technician was familiar with her role as an instructor. Okay, so what was done? The nursing instructor explained to the x-ray technician that despite her age and her attire, her background was sufficient to understand x-ray positioning. The x-ray tech, while taken aback, was respectful and apologetic to the nursing instructor once he became aware of her role. The situation was not reported. The x-rays were completed and the nursing student instructor continued to provide care to the patient and document the events surrounding the respiratory arrest. So what I would like for you all to do is discuss with me what are some of the attitudes and assumptions that were that occurred during the communication and interaction in this case. What are some of the tech? Well, let's start with the technician. What are some of the attitudes that the tech had?
He assumed that she was only a nurse when she was in a higher level position where she was able to understand the information that was given to her.
I thought it was more of like stereotyping in that sense because of like some men think that women are inferior, or that maybe it was her race had to do something with it.
Her race too.
Mm-hmm. Those are great. So assuming that she was a nurse, some stereotyping because she is a woman, or maybe her race came into play. What do you think that he thought about that she just didn't know, she didn't have the right level of knowledge?
I think also because that she's like, though they said that she looks young, that she's like underestimated like how much knowledge she could have, and also like
Right.
because he wasn't specifically like an X-ray technician, like he kind of like dismissed the thought that she would know what he knows because like they're not in the same field, but like people can know things just from experience. You pick up things here and there that she would know the same information that he knows.
Absolutely. So then there's the issue of age because she looked young, so he figured maybe she didn't know. But then you also mentioned that there's the issue of differing disciplines. So he was an X-ray tech and he maybe assumed that she was a nurse or a nursing student, and how could she know what he knew about X-rays? So that's a good point as well. Anything else? I think we covered a lot of the technician's assumptions. So let's see. The technician questioned why or how the African-American woman would have knowledge about proper patient positioning for x-rays. The technician erroneously assumed that the young appearing woman in scrubs was a nursing student. Okay, so you guys got all of those and a couple of extras, so that's great. But there are also assumptions and attitudes from the nursing instructor's perspective. So what do you think were the nursing instructor's assumptions and attitudes?
I heard whenever you're the first paragraph that you read talking about the patient, that like she would say like that some of the respiratory issues and things like that like some things were like imaginative. So I just think like sometimes like as a nursing instructor, like they like dismiss certain things. Like I feel like even if the patient's complaining about that even if you think it could be imaginative, you should still check it out like to begin with.
Absolutely, you're absolutely right. And so that happens more frequently than we would like to admit. But when patients are known to have mental health issues or suspected of having mental health concerns, that sometimes they're not necessarily taken seriously when they have complaints of other physical ailments. In this particular case, there was a nurse, a primary nurse. So she's the assigned nurse that works with the hospital. And it was the assigned nurse that works with the hospital that kind of blew off the patient's complaints. And so the nursing student went to her faculty member and said, hey, this patient has these complaints. I'm not comfortable. You know, what can we do? So there was kind of like a threefold nursing team. But yes, you're right. So what else did the nursing instructor assume?
I remember I heard that you had said that the nursing instructor, how when she introduced herself after he commented on like her, after he thought she was a student, how she introduced herself by first name only. So she made like the assumption that he knew that she was an instructor at the hospital and that like he knew who she was and that she knew more than what he actually thought she knew.
Exactly. So the nursing instructor, in trying to be friendly, introduced herself by first name, but the X-ray tech had no idea who she was. So that her assumption was that the X-ray tech would know based on her interactions with the nursing student that she was an instructor. But how would the X-ray tech really know that if they don't know each other? Right? Anything else? I think you guys captured those as well. So let's look. So the nursing instructor was dressed in blue scrubs, and having just left another patient room, she overheard the technician asking for help with the X-ray. She did not put on her white lab coat nor her badge before entering the room to help the tech. She spoke briefly with the nursing student. She introduced herself to the technician by first name and proceeded to offer her assistance. The nursing student instructor, having worked and taught on that unit for 3 semesters, was staggered that the technician would presume incompetence. She had previously worked in an ICU setting and was familiar with proper X-ray positioning. So that's another assumption, you know, that you have a certain level of knowledge or certain knowledge in particular areas, and you can't assume that everybody knows that you know it, right? So that's another assumption or attitude that the instructor had just by being an instructor. So gaps in knowledge, okay? Let's look at that. Lack of knowledge. So these are the gaps in provider knowledge. And remember, we're talking about provider to provider bias here. So this is just one example. A lack of knowledge regarding staff and student roles in the clinical setting. Providers should be aware that students and staff of all levels might be present on a care unit in the hospital learning environment. There is a lack of knowledge of disparities and discrimination. African Americans who serve in leadership roles are commonly encounter the assumption from unfamiliar persons that they are employed in lower tiered positions based on racial stereotypes. The lack of knowledge of disparities and discrimination, again, there's a preconceived gender and age stereotype that might contribute to personal biases when encountering unfamiliar people in the clinical setting. And then relying on medical attire customs to delineate rank. Beware of relying on old or outdated customs to distinguish a person's role in the clinical setting. People wear all kinds of things these days, and so you just kind of have to read badges or ask. But this can lead to erroneous assumption about a person's knowledge and abilities. Interprofessional practice, changing social mores, educational reform, and advances in professional development have led to diluted traditions regarding white coats, scrub color, and other attire. It's not consistent across the board, so you just have to remember, you just have to ask and not assume. Some cross-cultural tools and skills. When working with providers unknown to you, presume competence. Do not assume that a person's level of education or role based on race. Do not assume a person's level of education or ability based on age or gender. And do not assume a person's role based on his or her attire in the hospital setting. So we have some pearls and pitfalls here, but we're getting close to the 4 o'clock mark, and you guys did have some questions. So I want to just quickly go back and answer the questions, or make sure that I've answered the questions that were submitted. Let me go back here, screen share again. Okay. Q&A. What about violence and gender? The healthcare system is supposed to be unbiased. Oops. When you get severely hurt, you're supposed to know that when you go through those hospital doors, your color and background does not become a factor for why you didn't receive proper treatment. Your lack of healthcare insurance shouldn't make the hospital deny you because you are unable to pay for it. Whether you're in a gang or a transgender shouldn't matter. Racism and sexism are two sides of the same coin. So that's very true. I don't know that there's an actual, like, a question here, more of a statement. And I think it's very, very true that all of these things, we talked about the preconceived notions and just making sure that you check those at the door when you're dealing with people. All right, what are some steps the nurses can take to help improve the lack of health care that certain races are receiving? Well, the first thing is to be informed, and this is for nurses or this is for any healthcare professional. Be informed. Don't leave it up to someone else to continue to inform you. Seek information about how you can better the situation. Maybe you want to get into research. Maybe you would like to participate on the practice council in your clinical setting, so that you can make sure that these things are addressed. When you might be asked to serve on a search committee, maybe you can suggest that they hire more diversely. There are a lot of things and a lot of steps that can be taken. Right now, as a student, your main goal is to just really be aware of your cultural influences and how they may affect your interactions with others going forward. That's the first step. What are we doing now to make sure there is no racial bias going on during patient visits? For example, background checks on doctors, a committee that checks in with patients to see how their visit went. We can't make sure that there's no racial bias going on in patient visits. Racism has been here since we've been here, since the United States has been born. So, and it will continue to be here. We're not getting rid of it. We can mitigate some of the outcomes associated with it, and it's just going to take some collective action. We do background checks on doctors and nurses, and all healthcare providers all have to have background checks. But a background check won't show if you're providing differences in care to certain people. A committee that checks in with patients to see how their visit went. So we do have hospitals get paid for the quality of care and for those patient satisfaction surveys. So as a patient, you yourself should be completing your patient satisfaction survey, but you can also encourage your patients to complete their patient satisfaction surveys. And that is one way that we can start to really see the collective impact of disparities in healthcare. And then why is it important that we have more people of color in the healthcare field? Well, it's important that we have more people of all varieties and all backgrounds and all cultures. Transgender, people of color, people from different countries, people who speak different languages, people of different sexual orientations, women, people of different abilities. It's extremely important that we have representation from a bunch of different groups, because they come with the knowledge of what that particular section of their culture needs or wants or desires in their healthcare experience. Why is it that African Americans have a lower life expectancy than other races? For all the reasons that we just discussed. One term that you will hear about is a term called weathering. That's a new term. Weathering has been used to describe the impact of chronic social and environmental stressors that diminish your health over time. So it's hypothesized that for minorities, we have persistent exposures to structural racism and social stress, which results in the early onset of chronic disease. And we know that chronic disease can lead to a lower life expectancy. So if you want to look more up about that, Arlene Geronimus is the first person to introduce the concept of weathering. And we know that the chronic stress actually impacts us at the cellular level. So it's not just a mental health issue, it's the repeated activation of the sympathoadrenal system, which leads to cumulative hastening of aging, inflammation, and cell stress. So we know that there's actual a physical manifestation of stress and structural racism on people of color that leads to a lower life expectancy. And then what are the statistics with minorities of Asian descent? Just a brief search, Asian Americans face health disparities in cancer, chronic diseases such as heart disease, hypertension, and diabetes, mental health, and among the elderly. We're, of course, still collecting research on all of minorities from all different descents. So really, if you'd like to learn more, just do a quick Google search or even go to your library and do some searching, and you can find statistics on just about any cultural component and the disparities that they face in healthcare. Okay, so that is the end of the Q&A. Let me escape from here and stop sharing my slides. Thank you guys so much for hanging in there. I know we're a little bit past the 4 o'clock mark, but I appreciate you still being here. If you want, I still am here. If you want to ask questions or have more discussion, I can hang on the line. If you can't stay, feel free to go ahead and drop off the line. I thank you so much for being
Jamela,
here.
it's Jonathan Lopez.
Hi, Jonathan.
I'd like to say something about one of those last questions,
Sure.
just to qualify it. One of the last questions was about why is it important to have diversity in the healthcare fields, and I think that question needs to be. I think it needs to be framed in the fact that the most important thing in healthcare is that people are trained to do what they're supposed to do medically. It has to be understood though that within that group of people, you do find all races and all ethnicities of people that are qualified for that in that way. The first thing in medical has to be the fact that you have gone through the training, you've gotten good grades, you've done that stuff. It doesn't matter your race, your ethnicity, your gender, your sexual orientation, or anything. We're talking about a field where people live and die every day if you don't know what you're doing. So that's really important I think it's important to qualify that. The problem is that amongst, everybody, from people from all groups of people qualify for that, and that they're not being hired at the same rate. And that's where the inequity comes in, and the bias is that, you get a group of people that are all equally trained for a position, and then racial racism and this ethnocentrism comes into play when you're choosing the people that you hire or that are on your staff. So it's important for everybody to realize that, it is first and foremost, it's a matter of training and your expertise, but to lead, I think the problem is in leading in people into thinking that just because they're a minority race or a minority ethnicity, or that there's nobody from that pool of people that are qualified to do that. And I think that's where the discrepancy really lies. And that's where a lot of people get discouraged, because you do see more, like in the hiring practices, not just in the medical field, but all fields. You do see discrepancies on hiring minorities rather than majority groups.
Mm-hmm.
And you're still dealing with a group of people who are just as qualified as each other, but the people that are being chosen more often are the ones that tend to be part of the majority group. So that's
And
absolutely
a follow-up question to that, because you have to get into the school first to become the healthcare provider, right? So
yeah.
What can programs do to try to make sure that they have a diverse pool of students?
Yeah.
Yes. It's really I don't know if you all have heard of the social ecological model. It's really a social ecological model issue. The social ecological model tells us that at various levels, we're impacted as individuals. So you have the societal level, the organizational level, and within that, and then the interpersonal level and the individual level. So you can't really make changes at the individual level that are going to stick without making changes at the societal level, because that society is still going to impact down to the individual. And so as Jonathan is saying, and as Leanne are saying, there are systematic and systemic issues at play that perpetuate the stereotypes and the biases that contribute to poor health outcomes. And it is not the individual that's responsible for that.
Jamela, thanks so much for having our meeting. You're awesome.
Yeah. Thank you. Thank you all for being here. I was really wanted to have a little bit more conversation, but I realized my presentation was a little long.
Oh no, I mean this is something that would take multiple hours to actually accurately.
Yeah, and
address.
there's so many levels. There are so many levels to it. But please feel free if you have any additional questions or you just want to chat with me. Jonathan or Leanne can share my email address. Email me anytime. And I really hope that I see some of your smiling faces in the nursing school soon.
Absolutely. Thank you so much for doing this for us. It really ties everything that they're learning, I hope, together about sociology and some of the history of our country, those who are in the US class, tied right into some of our conversations earlier today. And the weathering webinar that you mentioned, do you happen to know if it's posted online? Because I could also share the link to that.
It is, and I'll have to find where it was posted because it was done through ODU, and she did post a link somewhere, but I'll have to find it and I will send it to you.
Okay, great. And then I'll share that with all the students.
Okay.
So, can we give Dr. Martin some snaps or claps for talking with us today?
I'm giving the clap back to you guys for joining healthcare at this point in time.
In 2020?
Yeah, in 2020.
I just wanted to say, hey, Dr. Martin, since it wouldn't let me log on earlier.
Who is
Sorry,
that? Oh, hey,
missed your
Sinead. How you
introduction.
doing?
Yes, doing okay.
Good to see you. All right, you guys, have a great afternoon. Thanks for being here. Thanks for inviting me.